We, in the last year, together with the European Hematology Association and the European Bone Marrow Transplant Society, developed a new consensus grading system for immune effector cell-associated hematotoxicity, or ICAHT, after CAR T-cell therapy. So what is ICAHT? This refers to profound and/or prolonged cytopenias. The grading system separates early, between day 0 and 30, and late ICAHT after day 30. In this analysis, we applied this grading system to a retrospective cohort of about 550 patients that received CAR T-cell therapy for LBCL, Mantle cell lymphoma, and multiple myeloma, spanning 5 different CAR T-cell products. And we analyzed sort of the severity of hematotoxicity, and then also compared it sort of across disease entities and across CAR products. And we found, for instance, that the incidence of severe and life-threatening ICAHT was actually a little bit higher in the patients with mantle cell lymphoma compared to LBCL and multiple myeloma. But that probably more fundamentally reflects differences in sort of disease characteristics. We also find that sort of the incidence of severe and life-threatening ICAHT is about a fifth of all CAR T-cell patients. So this, I think, is more of a realistic framework as to what we would see, for instance, with CTCE grading. And that's sort of what we have currently, CTCE grading, and we see that the new ICAHT grading actually does a better job at discriminating for severe infections than the CTCE grading does. And we see that the patients that had severe or life-threatening ICAHT actually had a higher rate of severe infections and severe bacterial infections compared to the patients that did not. We also saw that they had a higher non-relapse mortality rate, which was particularly driven by infections. And we found that they more commonly received transfusions and supportive therapies for hematotoxicity such as G-CSF, thrombopoietin agonists, and hematopoietic stem cell boosts. And then finally, we found that the patients with severe or life-threatening ICAHT actually had inferior survival outcomes in terms of both PFS, but also overall survival compared to the patients that did not. And we think that this grading system has sort of the advantage that we're now able to compare hematological toxicity, speaking the same language, using the same nomenclature, which will hopefully facilitate cross-trial comparisons of this important toxicity. And I think, or we hope, that developing a grading system is sort of the first step that we can now think about severity-based recommendations for management and for the diagnostic workup of hematotoxicity.